So this is, the idea here is basically a framework for conceptualizing behavioral economics and traditional economics under the same umbrella to look at nutrition interventions. And this turns out to be important for several reasons. Between 1700s and 1890s, psychology and economics were kind of considered under the same umbrella. All of the classical and neoclassical economists, Hume, Smith, Bentham, Jevons, Walras, Edgeworth, all considered psychology to be compatible with economics. However, as introspection began to fall out of favor in psychology, we started seeing this bifurcation, and we came up to what's called the Paretian turn, which Pareto stated, it's an empirical fact that the natural sciences have progressed only when they have taken secondary principles, and what he meant by that was psychology, as their point of departure. Pure political economy has therefore great interest in relying on as little as possible the domains of psychology. So what happened was this umbrella became kind of closed up, and through the, up until basically about 1980, and then during that time, between the 1890s and 1980s, we had all this work by Hicks, Allen, Samuelson, that went to an ordinalist and then a reveal preference approach, and then of course, obviously, Kahneman and Tversky's most important paper around 1980, we started questioning our foundations. But over the last 20 years now, we've seen this umbrella start to open back up, and many people, Matthew Rabin, Kammerer, Glitchmer, have started saying that possibly we can incorporate these under a common umbrella. So that's what I want to talk about today, the neuroeconomics. And over the last 20 years, we've kind of got this common umbrella opening up. So the framework I'm going to present really consists of 4 components. And those 4 components are, one, this kind of cognitive resource modeling approach, which has been used over the last half a century, at least in psychology, this computational framework. The cognitive resource model is based on some work by Kuhl and many others, the Journal of Experimental Psychology. Second component is a dual objectives component, which is based on a model, and again, this is for nutrition interventions, okay? A paper by O'Donnell, Rabin, and Rum, Journal of Health Economics, 2016. And then the third component is this dual system processing, which all of you probably heard of. And the final component is this integration, which is a paper by Rangel in Nature of Neuroscience in 2013. So here's kind of the basic framework. And again, in 8 minutes, I'm not going to get into a lot of detail. There's 2 components. One, in a food consumption and nutrition component, you get utility from 2 sources, the hedonic component and then also the health component. The health component has these discount factors, which could be due to intertemporal aspects of it, or it could be due to uncertainty. And of course, obviously, you have the cost component. Then obviously you have system 1, which is the reflexive, automatic, kind of mindless system that processes this decision. And then system 2 is the reflective, right, analytical, that all of you have seen about. Now, this framework provides you with kind of 3 major implications that are coming out of this cognitive resource allocation model. The first is, and this is based on the experimental evidence from Kuhl et al., cognitive effort is minimized, implying a preference for system 1. So we prefer to use the system 1 in terms of our cognitive effort. Resource depletion contributes to system 1 use. So as our cognitive resources get depleted, again, we move towards using system 1. And most importantly, hedonic decisions are associated with system 1, and long-term health-related decisions are associated with system 2. Now, what that implies for this little picture I have here is, in terms of the 2 sources of utility, we have system 1 being used in terms of processing hedonic. That's mainly through sensory perception, taste, feel, touch, in a food context, mainly taste. But then system 2 is used in terms of evaluating the second component, which is the longer-term health component. Okay, so that takes a much more abstract type thinking and processing, and also cost money, time, and effort. So what you see immediately here is from this approach that kind of the traditional economic variables and analysis is kind of focused on the system 2, the second component, and system 1 is more where a lot of the behavioral stuff will come in, okay? So here's a diagram out of my book on food and nutrition economics. And so we kind of have two types of stimuli. Stimuli that operate through system 1, which is through our sensory, sight, taste, smell, social. A lot of those are behavioral factors that have been used in the literature. And then system 2 is some stuff we kind of think about in terms of traditional economics: budget, prices, time, nutrition information, statistical information. Obviously then those are processed, and they can be processed either fast and at the top part through system 1, and obviously there's interaction between system 1 and system 2. These are put together, you evaluate hedonic benefits and the health benefits based on that utility function, and then you end up with this final decision. Now, all of this is obviously moderated by many factors. It could be education, hunger. Hunger obviously is going to lead you to more system 1. But if someone is on a diet, they may think more carefully and be using kind of system 2. All right. So why is this useful, this framework useful? Again, because we've got behavioral economic components and traditional economic components within the same framework here. You end up able to think about a little bit what type of intervention may be effective in a nutrition context. Do you go with a traditional intervention or behavioral intervention? And this table here is kind of based on a lot of stuff we found from the literature. So suppose you have a soft drink tax, right, which is a traditional economics intervention. That is going to probably be processed with system 2, and the likely effectiveness is going to be relatively low. That's what the literature is finding. The results are very mixed on soft drink taxes in terms of their effect. They're relatively small. Then we have a lot of things that nutrition educators focus on, facts panels on the back of foods, nutrition curriculum. All these are knowledge-based things. So these are things that are a little bit more abstract and not directed at the senses. And again, likely effectiveness of those is relatively low, relatively speaking. And then we have a lot of literature on smart lunchroom design, default effects, environmental cues. Those seem to be working pretty well. So what's the conclusion from this within 7 minutes that we can detail, you can get into? This neuroeconomics, cognitive resources, and dual systems and objective approach to thinking about health decisions is kind of a unifying framework. I'm not going to stand up here and say there's a canonical model, but it is a unifying framework that helps you analyze and take into account both traditional and behavioral factors and avoid this tension that we had for many, many years between the two. And finally, and this is very important, most progressive programs now, you'll see this with some of the funding agencies, they will not only consider the content of the information being provided, but they'll also consider ways to reduce cognitive load in order to make them more effective. So the additional component here is taking into account the cognitive load in whatever intervention you have. Thank you. Hello. I can repeat it if you want me to, Justin.
Questions? We've got time for one or two. It's on now. Yes.
It's on now.
Arlene Ashe, University of Massachusetts Medical School. So it seems like we need to learn from the advertisers, right? You talk about taste being reflexive, but people have been taught to have certain kinds of tastes which are different from the ones that we had 30 years ago. Taught to go more for sweet, away from fat. So it seems to me as if an implication, I mean, I loved your talk and thought you did great in the time allotted, but But it really seems as if the point is how we get the message across, and we now understand that issuing a fact sheet isn't going to do it.
Thank you for your question. I think it's more than how we get the message across. I think it is how we get, if by how we get the message across, you mean taking into account the way it's presented and how it could be processed, right? So, for example, if you know anything about the nutrition interventions, they went from My Pyramid. If you remember the My Pyramid, which was extremely complex and hard, even though it was a visual, it was hard to understand, right? In terms of the pyramid, the different colors, what all those represent. What did they go to? They went to My Plate, right? My Plate, much more simple, much simpler, and it was representative of what you would be engaged in at the time of eating. So that's a good example of going to something that requires less cognitive processing. So that's the kind of the point, yes. So if that's what you mean by how we present it, I agree with you completely.
Thank you, George.
Yep.
All right, our next speaker will be Jeremy Borofsky, presenting Survival Expectations in the Era of Mass HIV Treatment, a mixed method study in rural South Africa.
All right, thank you very much. As was said, this is a nice follow-along from George's presentation because it's one example of taking that broader umbrella where we put economics and psychology together to better understand our interventions. The focus here is young adults' perceptions of HIV in the era of mass ART, and we're using mixed methods in rural South Africa. So my name is Jeremy Borofsky. I'm at Ideas 42 as well as a non-resident fellow in Brookings Institution. I want to also recognize my collaborators, Jacob Boer, Dubulikle Zita, Janet Seeley, and Till Berninghausen. So there are more individuals living with HIV in South Africa than any other country in the world. Adult HIV prevalence is 20%. Nevertheless, life expectancy for the HIV positive is now approaching those who aren't living with HIV as a result of mass ART availability. With this rollout, it's produced a historical increase in adult life expectancy in rural South Africa, found to be approximately, using updated data, about 18 years, from 49 to 67, across the expansion of ART. And although, nevertheless, it's widespread and by and large free, there is only about 50% take-up of ART in rural South Africa. So when we're understanding this study and doing this research, we have a decision-making model in mind that's based on young adults facing costs, the decision to take costly actions for their health and education and human capital formation generally, that then determine their trajectory throughout the rest of their life. And one of the key inputs to making those decisions relates to the beliefs that individuals, young adults, have about the future payoffs those actions today will produce. When it comes to HIV testing, treatment uptake, as well as risky sexual behavior, and other human capital formation such as staying in school or continuing on. So the study questions that we are approaching, therefore, is how young adults perceive their own survival expectations in the era of mass ART with this enormous expansion in access to treatment that has reduced mortality related to HIV and increased life expectancy. In addition, as we'll see, if beliefs haven't completely updated as a result of this large shift in survivorship, why haven't they? And finally, we'll describe a series of ongoing work to identify whether or not survival expectations can in fact be shifted by intervention, and then whether those have knock-on effects on human capital formation decisions by young adults. So the context of this study is an area in rural KwaZulu-Natal, which has even higher HIV prevalence than Africa or South Africa on average, approximately 1 in 3 adults. In addition, it's a context of high unemployment, where there's also high prevalence of risky sexual behaviors and risky behavior generally, as well as low hope for the future because of lack of opportunity, as well, and low life satisfaction. The specific data and methods that we're using is a combination of quantitative data from a demographic surveillance area, the Africa Health Research Institute, and also qualitative data that we're collecting, which includes interviews and focus groups of young adults 18 to 29. And we use a series of focus groups and interviews to assess perceptions of HIV, understanding of the effectiveness and availability of ART, as well as survival more generally, both for an individual and in their community. In addition, we've created an intervention video that we've pilot tested at this point, which provides examples from the community of individuals who have lived a long time and successfully on HIV treatment as a way of showing in a low cognitively taxed way the benefits of staying on treatment, and in a way that is both informational as well as emotionally evocative. In addition, we have a series of pilot questionnaires that ask about survival expectations in this context. So empirical fact one, shown graphically here, which I already described, this historical increase in adult life expectancy as a result of the scale-up of ART. Nevertheless, from our qualitative data, we've also found empirical fact two, which is that young adults in rural South Africa believe that survival is actually quite unlikely, indicating the possibility that, in fact, there hasn't been updating as a result of the shift in survivorship as a result of treatment availability. Some representative responses from our qualitative data include the two quotes that I have here that we collected from last year. One is, and I'll just read it out, from a 24-year-old female. I can't believe that I can reach age 40. People are dying, especially youth. We are dying fast now. We are dying like flies. We are living in difficult times. And then another quote from a male who's 20 years old. I was answering the question about, do you think I will live up to 60? I thought 60, I would be dead by that time. So this is a very common theme we saw in our qualitative data collection, which is that most young adults, in contrast to the survivorship changes that have happened in their community as a result of HIV treatment, haven't necessarily updated their beliefs about what will happen in their future. So this is so the red line shows survivor probabilities. This is just showing the large shift in survivorship that occurred as a result of the HIV expansion in the form of survival probabilities. The red line showing survivorship in 2003 before ARVs were provided, and then the large increase in survivorship in 2014. And it also shows some preliminary data on our quantitative estimates of what young adults perceive their own survivorship to be, and we see that it's much closer to the previous survivorship curve that prevailed in the area as of 2003 before access to treatment. So some of the reasons that we are thinking through when it comes to this difference between perceptions and actual survival is that it's quite possible that young adults are using mental heuristics more towards system one thinking as a way of identifying what will happen in their future survival, and then using that as an input to make decisions about their human capital formation actions. So it could be that observed, they're using a simple heuristic where they're looking at previous generation survival, and so therefore not updating. Or it could be there's some aspect of the most salient deaths in the community, especially for a young adult where their social networks are related to other young adults, is that they're using the salient deaths in the community, what they hear on the news. It could also be that there's the modal death in the community. And finally, it could just be that they're answering the question in a broader sense, that it's more likely to reflect both overall opportunities in the area. So when it comes to the modal death, it actually is the fact that even though there's been this large shift in survivorship in young adults' ages, nevertheless, the modal death, because of population distribution and the fact that it's been so hollowed out by the HIV epidemic in addition to migration, means that the modal death is still in 30, 40 years as a result of the population distribution. So although a heuristic that can be effective, it is in fact unhelpful oftentimes for young adults. And this just shows again that the shift in projected ages at death, even with that modal death. And I just want to very briefly show some examples of our informational video here. These are our peers that we have recruited and have in our video, showing young adults the benefits of ART treatment. And I'll just finish by saying we've done some focus groups and shown that there is some scope by showing these this video intervention to young adults to shift both perceived survival as well as some measures of hope. Of course, we are doing focus groups and piloting, and we will do additional tests in the future. So to conclude, we've seen that in our qualitative interviews and some of these pilot questionnaires that aware of ART is high, and also awareness of its effectiveness and availability is high. Nevertheless, survival expectations among young adults are low, and that has led to the possibility that this reduction in HIV-related mortality may not be fully incorporated into current survival expectations. We've identified these potential reasons for not updating expectations, and we then have initial evidence that we'll continue to look for more formally in a randomized experiment by providing the video to a series of young adults to determine whether survival expectations may shift. So, yeah, thank you very much.
Maybe time for one quick question.
Thanks, that was really super. I don't know if you have data to be able to do this, but I think an important thing to do would be to divide the young people between who is infected vertically and who is infected horizontally. Because it might be very different if you were living with HIV your whole life versus having more recently acquired infection.
We're not asking questions explicitly on that because of the sensitivity.
But you could probably figure it out with medical records, I would think, no?
There is some possibility of that. Or what we've been asking in order to sort of elicit the differences is to ask people for themselves individually, their survival expectations versus their community overall, and look at the differences. So we are, and so it is possible, and we will be doing administrative follow-up for, and linking them in records, so we will be able to, although not necessarily be powered, to see differences in actually HIV prevalence.
You might have to tailor your video slightly differently depending on that.
And, I mean, there was some qualitative evidence that there is differences in how people take it as well. So yeah, we'll continue to do. Yeah,
that's great.
yeah, thanks. All right, thanks.
Next up is Eliana Baranjo, presenting the role of physician and environment-specific factors in the adoption behavior of new technologies in the English NHS.
Good morning. Today I'm presenting joint working in progress with my colleagues that I just listed here in the front of this slide, where we are interested in exploring the role of physician and environment-specific factors in the adoption and diffusion of new technologies in the context of health systems. We depart from practice variation and adoption, innovation and adoption literature to try to understand how specific physician characteristics that have been listed in the literature in parallel with hospital and health system characteristics, they do help in understanding variation in the healthcare utilization, in the innovation adoption in the context of health systems when we control for patient-specific characteristics. And we choose a very interesting setting to empirically explore these issues. So basically, we take the case of elective colorectal cancer surgery in the English NHS, and we are interested to see how such high incidence disease such as colorectal cancer, who shows to have large economic burden for the British taxpayers, how this is actually delivered across the English NHS trusts. So we basically, colorectal cancer is treated, there are two treatment options. So there is the traditional open surgery resection, which is an invasive procedure, and then there's the innovation, which we can observe in data, in hospital administrative data, which is laparoscopic surgery that has been shown in the beginning of the 2000s to be cost effective. So several observational and RCT studies show that laparoscopic surgery for the treatment of colorectal cancer delivers better health outcomes, lower length of stay, and lower infection rates. So this is a nice setting to study in the context of the English NHS that is seen to be a slow adopter of innovation. There's high variation across the country in practice and in adoption of effective new technologies, even besides the fact that there are several national policy interventions to try to homogenize delivery of care across the country. So it seems to be an interesting setting to study. I wish I could have time, which I don't, to explain to you how rich our data is. We have the universe of elective colorectal surgeries across England that are performed by 181 NHS trusts and 2,381 consultant surgeons. We construct a consultant ear panel, which basically matches several secondary data, administrative data sets that include hospital episode statistics between 2000 and 2013. Then we are lucky to have workforce data that enables us to track back since 1992 the job career of these consultants, where they've been practicing. Also, we have information on the training of the consultants, and finally, we do have extensive information at trust level from annual reports on financing, staffing, and other provision measures at hospital level. We do have interesting primary data collection that I also can tell you if you are interested in, but basically we think that understanding next to consultants and to clinical experts what are the factors that might be embedded in explaining this practice variation is important, and we carry that across 20 semi-structured interviews to surgeons. So this is basically the overall picture of diffusion of lap surgery for the context of colorectal cancer in the English hospitals. We have this red, very nice S-shaped traditional diffusion curve in red, which shows us nearly zero numbers in 2000, so it's pretty nicely because we can see the starting of the take-up of the technology, and then a sudden jump that follows before 2006, when the major clinical guideline is introduced in the country to foster the uptake of this technology. At the same time, there is, in parallel, a declining trend on the traditional invasive surgery that you can see in blue. So we basically, and very briefly, we are interested, and we were interested in this first descriptive approach to this extremely rich data to disentangle how consultant fixed effects in contrast with hospital fixed effects. So hospital embedded characteristics explain variation on this innovation uptake. And we do this by exploring consultant mobility across the different hospitals. This is basically an approach that has been done in other contexts where AKM, which is mentioned above in Econometrica, does for FEM employee matched data for the French sector when evaluating performance of individuals. So we basically study adoption of laparoscopic surgery and diffusion. We both do that. What I mean by adoption here, we basically model the probability of a consultant becoming an adopter in year T after reaching a certain proficiency level of tackling this technology, and the diffusion by measuring the share of surgeries that consultant I in year T does laparoscopically. So we do these as a function, both cases as a function of a vector of several characteristics, consultant characteristics, hospital characteristics, both that are time varying. And then we control, and we are extremely interested in controlling and observing and identifying consultant, hospital, and year fixed effects. We also control for a patient suitability score that we construct on patient-level data in order to see how suitable is a patient according to his characteristics to receive LAP treatment. So we interestingly see, and we observe a very big resistance to adopt this technology across amongst these 13 years. More than 17% of our consultants are not adopters. Though the consultants individually, are responsible for 28% of variation in adoption and 70% of variation in the diffusion process of the technology. This goes in line, and to finalize, with the results, the first results that we get from our regressions on regressing adoption and diffusion behavior. Basically, we see three very interesting results for now. We see that what explains adoption does explain diffusion of lap surgery in this context, that consultant characteristics really matter, much more than the environment where they are actually performing these laps. So inherent characteristics such as being young, female, training overseas, or being a general surgeon seem to actually promote adoption and diffusion of LAP. Experience also plays an important role, specifically experience on colorectal cancer surgery, but also on performing LAP on other clinical contexts. And it seems that being a mover, moving across different hospitals, seems to be negatively correlated with adoption and diffusion. But there might be a selection problem over there. Finally, it's interesting to see that hospitals don't play any role in explaining the variation in this adoption. And it seems that much more important on the environmental side of things, that networks between consultants seem to really play some type of significant role in explaining adoption. For now, it seems that that effect is negative. So, to conclude, it seems that individuals, physicians, they are the center role on deciding to adopt or not a new technology, even a new technology that is cost-effective. Even in the context of an English NHS that centrally designs and implements clinical guidelines that creates incentives to homogenize practice and delivery of healthcare. So, thank you very much. I exceeded, I think, 1 minute the time.
Time for maybe one question. Come on down.
Hi.
Thank you very much. It was really nice. Alexandra Torbica from Bocconi University. Just one question. You mentioned in the characteristics of the consultants, physicians, that you somehow control for their attitude to innovation. So I'm just wondering, how did you operationalize that concept? How you would, measure their innovativeness attitude, and in addition, whether you have the chance to control for the presence of the key opinion leaders in the trust, because it has also been shown to be an important factor for diffusion of technologies. If the key expert in the specific hospital adopts the technology, will act as a leader for the other more junior doctors to do so. Thank you.
Okay, thank you, Alexander. Yes, so in terms of an attitude towards risk, for now, and we are basically assuming that that attitude is time invariant, so it's somehow embedded on the personality of the consultant. And from the qualitative work we've done and we talk with consultants, that seems to be the case. So it seems that consultants tend to, in an innate way, tend to be very different in relation to the way that they approach new high-tech stuff. So because we in the way that we methodologically approach this problem, we control for consultant fixed effects, and we actually can identify it in which of one of the 2,000 consultants how they actually explain variation in adoption diffusion behavior. We can control for that. But of course, that's time invariant. We do have a plan in the future, a follow-up in this project to survey, to do a survey, to run a survey on consultants and maybe be able to measure if there is inconsistency on that risk behavior across time. In regards to the key opinion makers, well, these, not to forget that consultant surgeons in the context in the UK context, they are pretty senior people. So they do have already some seniority in their role. And they are definitely close to the opinion makers, not only on their hospitals, but also in a national context. So that means that, the seniority that we could be concerned about seems to vanish away in this case. But we are right now running a study where we are modeling social networks, and one of our measures to deal with what you ask for is actually to measure the distance that each of one of the consultants has in relation to pioneers across the country. So we are in the process of running that. Thank you very much.
All right, our next speaker is Gigi. She's presenting the effect of a mystery shopper program on prescriptions in primary care, results from a field experiment. And as I look at the clock, halfway through her presentation, we'll be halfway through the session, so far so good.
I'll be quick, so don't worry. Good morning, everyone. My name is Gigi. I'm a PhD student from University of Oslo in Norway, and today I'm going to present to you the project, the effect of mystery shopper program on prescriptions in primary care, a field experiment from China. So this project was a collaboration with Shandong University in China. One important aspect of healthcare quality is physicians' prescription decision, and overprescription occurs when doctors prescribe unnecessary or excessive medications to the patients. And it is, of course, a waste to any patient or society who bears the cost. And in many cases, if the risks outweighs the benefits of the medication, and it would give a negative impact on patients' health. And one typical example is antibiotics. Overprescription of antibiotics is unfortunately still very common in many countries in the world, making antibiotic resistance one of the biggest threats to the global health. One possible reason we think that overprescribing is that patients, they have much less information than the doctors. So this asymmetric information might affect doctors' incentive for quality delivery, especially when the doctor's income depends substantially on the sales of the prescribed medications. Previous studies have shown that overprescribing can be mitigated by interventions combining auditing or monitoring with reminders, feedbacks, and education. But we were wondering, can we reduce overprescription by simply announcing a forthcoming audit to the doctors? So with these questions in mind, we conducted a field experiment on 96 primary care clinics in China, and this is what we did. So we randomized 96 clinics into a control and treatment group. And we informed those in the treatment group that we were going to send a pseudo-patient to their clinic, and the pseudo-patient would evaluate the quality of the service of that clinic. And we presented the details of the audit in both the written and oral forms to the doctor. And we also presented an endorsement letter from a local health center that is affiliated with the biggest hospital in the city. We also showed this letter to the doctors. And we call this intervention mystery shopper intervention because we didn't tell the doctor who was going to conduct the audit and when it was going to happen. We then recruited 13 healthy medical students to play a role as pseudo-patient. And pseudo-patient, they were scripted to present some common cold symptoms to the doctors. For example, a sore throat and feeling fatigued. And according to official guidelines, no antibiotics should be prescribed in the case of common cold, and other prescription medicines are not necessary for the symptoms that our pseudo-patients presented. And 3 weeks after the intervention, our pseudo-patients visited the clinics and presented the common cold symptoms and reported back the doctor's prescription behavior. So, did our mystery shopper program work? Well, we found a significant reduction in non-antibiotic prescription in the treatment group. However, those in the treatment group, they prescribed just as much antibiotics as those in the control group. So to wrap it up, announcing a forthcoming audit does reduce the overall overprescription in our study, but to effectively reduce overprescription of antibiotics, further studies are warranted. Thank you very much. Thank you.
Any questions?
I'm just curious about how you interpret the reduction in general prescribing. Is this that the doctors don't actually know what the right things are to prescribe, and they don't realize that the antibiotics are not indicated? How do you interpret the results?
Sorry? So if I heard it correctly, you were asking how I should interpret the results, mainly in terms of the antibiotics. Is that what you're asking?
Well, in terms of the reduction in general overprescribing, what is the message that the providers are getting? How do you interpret these results, which are contrary to your original hypothesis?
Yeah, with a focus on the differential between the antibiotics and the non-antibiotics. Is there
Okay,
anything-
yeah, thank you. So for the reduction in overall prescription, because in our case, the pseudo-patient presented the common cold symptoms, and in this case, that no any prescribed medication is needed. So if a doctor is concerned about the quality of the service, then the doctor would actually just send the patient home instead of giving any prescription. And in our case, the doctor's income are dependent on the sales of the medicine. So we're thinking that the reduction of overall prescription, that makes sense because you're telling the doctor that we're auditing you, and so the doctor would behave more altruistic towards the patient. So that's the reduction of overall prescription. But in terms of antibiotics, we didn't see any effect. So one possible reason could be that those doctors in primary care clinics in China, they might not know or they might not recognize how severe it is, this adverse effect of overprescription of antibiotics. That's one possible reason. And the second reason is that since we only informed the doctor about the fact that we're going to audit the quality of the service, so I guess different doctors have different views on what is good quality. Maybe when you, because I talked with the doctor and the doctor says, you know, if a patient comes to visit me, I am expected to give something back. So I guess that's another reason for it. Yeah, but we're still studying on it. So yeah, thank you.
All right, our next presenter is Lawrence Jen. He's presenting decision-making under the hot hand fallacy.
Oops. Don't want. Let's see. Great. Thank you. Thanks, everybody. It's wonderful to be here. Nice to see some familiar faces from the pre-Congress session. Today, my name is Lawrence Jen. I'm a PhD student at Cornell University, studying economics. And today, I'd like to talk about my paper called Decision-Making Under the Hot Hand Fallacy. So hot hand, let me start off with a belief in the hot hand. Hot hand belief refers to a belief in streaks of outcomes. And this is a widespread and almost universal belief in sports, including myself as a tennis player. And if you Google hot hand, you'll get images of ESPN news coverage of the hot hand, even in golf, and some more news about Steph Curry's hot streaks. And the seminal paper by Gilovich, Valone, and Tversky in 1985 were the first to show that actually, contrary to such a widespread belief, there's in fact no empirical evidence to support that performances in basketball are autocorrelated. And thus, they coined the term hot hand fallacy. And since then, there's been an explosion of hot hand research, especially in psychology. And there's an ongoing debate about whether the hot hand is a fallacy or an actual effect. I deviate from that literature slightly because my focus is not on whether the hot hand is a fallacy or not, although I do contribute to that part of the literature. I focus on whether these kinds of cognitive mistakes result in decision-making mistakes that are economically costly. And here are some motivating examples. This is important. We care about this because these kinds of cognitive mistakes can occur in principle in virtually any setting where there are sequential outcomes and that are skill-based. So you could imagine, of course, a classic example would be that a sports player becomes overly aggressive during a hot streak, and as a result, that might incur a cost to their performance. In finance, you could imagine that a financial investor feels overconfident during a hot streak and may pursue a very aggressive investment strategy and may insufficiently diversify risk. That would have financial consequences. Also in medicine, you could imagine that a physician who's subject to the hot hand fallacy may go through an unlucky streak of patient complications, and as a result, may be more likely to perform a defensive procedure to the next patient. And this was something that came up during my discussion over the weekend, that it's also possible that a person may be more willing to, for example, drunk drive when he's been on a streak of not being caught. So these are some of the motivating examples, and in this paper I studied two of them. First is professional darts. This is a clean, ideal context for testing the hot hand, which I'll talk about in a bit. And to just summarize the results, I do find that hot hand momentum is real, so it is not technically a fallacy, but players do systematically overreact to the hot hand, and as a result, incur a cost of about $1,500 of tournament earnings. Next, I turn to physician decision-making in childbirth, and this is a work in progress. Of course, admittedly, this is a much more complex setting, but much higher stakes. And the hypothesis here is that physicians are maybe more likely to perform C-section, which of course is a more invasive procedure that's not ideal for non-high-risk mothers, after a streak of bad patient outcomes, more specifically bad outcomes in vaginal delivery in the recent past. Okay, great. So why is darts an ideal setting to start off testing the hot hand? There are no interactions between players, no teammates. There's one opponent, but you don't directly interact with them during the game. This helps us eliminate a lot of alternative psychological mechanisms that coincide with the hot hand fallacy. Next, the decision choices are very clear and observable in the data. This is which target to go for. And finally, there's a clear objective function. So every dart player, at least in the beginning of the game, is trying to hit as many points as possible. So I'm going to do something unusual and dedicate my valuable 10 seconds to show you a video. Great. So darts is actually quite fun to watch. So the targets that they were going for at the top is called triple 20. It's worth 60 points. That's the maximum number of points that's possible on a dartboard. The target that the last throw was aimed at is called triple 19, which is worth 57 points. That's the second highest, and so forth. And the question is, well, I asked two questions: whether there is a hot hand momentum, that is, are they more likely to hit the intended target after a successful hit? And the next question is, are they more aggressive when they have made a successful hit in the past? So here's a result of the first question. Does the hot hand exist? The short answer is yes. There's a significant hot hand momentum, so they're 8 percentage points more likely to hit the intended target after a hit. And this corresponds to about 19% increase in the hit rate compared to the mean, so it's very large. Next question, do players respond to this? The short answer is yes. It looks like they are 11 percentage points more likely to go for the target 60. That's a slightly riskier, higher reward target. They're more likely to do that by 11 percentage points after a successful hit. So this is qualitatively consistent with a rational model, taking advantage of the momentum. But we also do see a significant response to a successful hit 2 hits ago after controlling for hit T-1. And that is an indication, at the very least, of some overreaction to the hot hand because a hit 2 hits ago does not improve your hit rate. Next, this is the nicest feature of darts. For every throw, I can use the player's data to figure out which target the player should have thrown at to maximize the expected number of points. Okay, I have 1 minute left, and I have probably 5 more slides. So I'm just going to skip over and just show you that the red line shows the player's reaction to the hot hand, and the blue line shows the optimal reaction to the hot hand by the rational benchmarks. And what we see is that for the vast majority of the players, we see a significant overreaction of the hot hand. Okay, so the two questions are the findings generalizable to other skill-based tasks with sequential outcomes? And more importantly, what about other contexts where decision mistakes are significantly more costly and higher stakes? So I think childbirth is a compelling environment to study this because First of all, as patients, we believe that physician decisions should not be influenced by sequential effects like this. And next, physician decisions are fully observed in the hospital data in this particular context, whether the childbirth was delivered vaginally or by C-section. And this is not true for many other procedures. And the fallacy is, the hypothesis here is that a physician who's prone to the hot end fallacy would believe that the probability of success of the procedure decreases during a bad streak. And I would love to test this. This is still a work in progress. I do find suggestive evidence, but with a big caveat that it's with imperfect data, and I'm waiting for the main data set, and hopefully I'll be able to present the main results to you next time. So thank you so much. If you have any comments, please send me an email.
All right, any questions for Lawrence?
So doctors, and I would presume dart players, well, let's think about doctors. Doctors have some unobserved skill that's actually unobserved to them. And we want them to be learning about their own skill and adapting their decision-making based on their skill. If I'm better at this surgery rather than this procedure, I should do relatively more of that. So how do you distinguish that model from the hot hand model, which is more about temporal variation rather than my underlying skill level?
Yeah, so excellent question, thank you. So that is what I would call some form of learning or Bayesian learning about one's permanent skill. And there's definitely a distinction between the hot hand and permanent learning of one's permanent skill. How would I be able to distinguish that in the data? It's going to be hard. This is why it's nice, what's nice about darts, but more complex in the physician setting. That said, one thing I could do, which I plan to do, is to look at very experienced physicians. And the story is that if they're a Bayesian learner, then a couple of extra observations in the recent outcomes should not influence their perception of their permanent skill. One could still argue that it's not a Bayesian learner, but maybe a different kind of a learner who implies one's permanent skill from the recent experience. That kind of story would be very hard to eliminate and test from the data. But if you have any suggestions and ideas, I'd love to continue this conversation with you next time. Thank you, though. Thank you.
All right, next up we have Thomas Schober. He's presenting participation in health screening for children and young adults, results from a field experiment on financial incentives.
Thank you. There is a large literature on the connection between childhood and life cycle well-being. So the early conditions in life, what happens to you in your childhood, has long-term consequences, for instance, on your health or even your labor market outcomes when you're grown up. And with this in mind, there are programs in many countries which try to improve these early life conditions. And one example are the so-called health and development checks for children. They focus on the early identification of disorders or the prevention of diseases in general. And there is also evidence that such checks may also be cost-effective and efficient, so that the early treatment or prevention of diseases is less costly than later treatment. The question, of course, is how to motivate families to participate in such screenings. Because we know from other results that families with lower socioeconomic background typically use lower preventive health services, and we suspect that such programs are most useful for such families. One way to motivate is with financial incentives, and this is what we look at. Can financial incentives effectively increase screening participation? There's of course some evidence on how financial incentives work, but there's nothing on child health checks as far as we are aware of. So the program I'm talking about is called Health Check Junior. This is a program by the Austrian Social Insurance Authority for Business, and it is targeted at children between 6 and 17 years. It includes a visit at general practitioners and pediatricians, and it includes an anamnesis and a physical examination to identify potential health problems, and it also includes a lifestyle coaching for the child and the family for health prevention and promotion in general. And on top of this program, we put our randomized controlled trial, where the control group received a general invitation letter, and the treatment group additionally get a shopping voucher worth of 40 euros if they participate in the screening. So this is the financial incentive. Just a short sentence to the institutional background. We're talking about Austria, so we have a mandatory health insurance which covers almost all costs of healthcare. And the program I'm looking at comes from the Social Security Institution, which is responsible for the self-employed individuals and their dependents. We have administrative data from this Social Security Institution, where I can see the program participation and the assignment and the healthcare utilization between 2012 and 2015. And I can match these data to other data sources, namely the Austrian Birth Register and the Austrian Social Security Database, where I have some information on socioeconomic background of the families. I'm showing you the results of simple linear probability models, where I estimate the effect of the shopping voucher on health check participation. And then what I'm interested in, effect heterogeneity. So how do families with different characteristics react on this financial incentive? The results show in the first column just the shopping voucher effect on health check participation. It shows that the participation increases by about 7 percentage points. The mean participation in the sample is about 6 percentage points. This effect is rather stable if I include further covariates, and also if I split the sample in column 4 and 5 into children below and above 12 years. So it's a rather stable effect of 7 percentage points of the shopping voucher on participation in these health checks. But then when I look at families with different characteristics, I see some interesting patterns. For example, when you look at the at the bars here at the bottom, it's just the coefficient of the effect of the shopping voucher, which I've plotted here. And you can see the lowest bar, I just look at families where the mother has a low level of education, so owns only compulsory education. And the second bar is a middle level of education, and the third bar is a high level of education, so upper secondary or tertiary education. And you can see that the effect increases with the educational level of the mother. And this is true for the children sample, so children below 12 years, and also the teenager sample, children between 12 and 17 years of age. In the top, I did the same in terms of income, so I split the sample based on the income level of the parents. And what may be unexpected, you can see here that the effect is stronger where the families have a higher income level. So they react stronger on the financial incentive than families with a lower income level. Further heterogeneity with respect to past healthcare utilization of parents. Again, at the bottom, I looked at if the parents themselves participated in health checks for adults in the 2 years before we sent them the invitation letter. And we see here that participation, that the effect of the shopping voucher is stronger for families where the parents also participated in health checks in the past. And this is also true for both samples, again, teenager and children. And in the top, I made a more general picture about if they visited a GP for any reason. And there, the same picture. If the parents visited a GP in the past, the effect is also stronger. So to sum up, the shopping voucher raises participation by about 7 percentage points, which represents about 200% increase. So the control group is a 3.3% participation, and treatment a 10% participation. We see a large heterogeneity, and we see large effects for families with a higher socioeconomic background and families with a stronger attachment towards preventive healthcare utilization. So to come back to my earlier question that I posted at the beginning, so do we get the right people with this financial incentive to these checks? Probably not. But of course, to finally answer this question, we would have to do a full welfare analysis where we look at the costs and the benefits of the participants, which is of course a difficult thing. What we can do a little bit, and we plan to do, is to look at subsequent health or healthcare utilization after the health check. So what happens after the children participated in the screening. Thank you.
Thank you, Thomas. Any questions or comments? Yes.
Hi, Thomas. Thank you very much for the interesting presentation. I'm just wondering, I mean, this seems like something that is reasonably, or has the possibility of being reasonably common across a range of behavioral interventions such as this. And I mean, it's rarely that sort of monotonic that you see it sort of all the direction pointing toward those who, you know, the marginal benefit is likely to be lower, as you're suggesting. So I'm just wondering if there's anything specific to the intervention you think that was the reason why, or this is, I mean, also it's low take-up overall. So maybe there's like low information about the benefits of it or of the program overall, just a little bit more about the context.
Mm-hmm. Yeah, I'm not pretty sure why we find these effects. So I think those who are just more aware of their own health, they also then care about these checks again. And so they are more easily pushed, even with financial incentives. Although the relative incentive should be higher for low income families. So this is a little bit a surprising result, but this is a plausible explanation that they simply have more attachment to their own health or care about it more, think about it more.
Is the price still positive either in cost, like opportunity cost of time? Is it like a relatively small incentive compared to what it would take to go?
It's a difficult question, of course, yeah. But this could also be a potential explanation that the cost of time is different between the families, yeah. But of course, it's difficult to measure.
Can you help us benchmark the size of the incentive? What does it mean? Is it a sandwich? Is it
No, 40 euros, a shopping voucher, 40 euros.
40 euros?
Yeah.
So it should be meaningful.
Yeah, it should be.
Thank you, Thomas.
Thank you.
Our last presenter is going to be Manoj Wahanan, presenting Can Individuals' Beliefs Help Us Understand Non-Adherence to Malaria Test Results? Evidence from Rural Kenya.
Thank you, everybody. I was not sure we would be able to get through in time, but it looks like we have plenty of time to get through. I believe I have 8 minutes and we'll wrap up in time. So this is work that we've been doing jointly with Elisa Maffioli, who is a PhD student of mine in the economics department at Duke, and Wendy O'Meara and Liz Turner, who are both colleagues at Duke as well. So before I jump into the details of the project and what we are going to show, the key question we were trying to answer at this point was to understand how do individuals make decisions under uncertainty. Specifically in the context of malaria, we know that in countries like Kenya, one of the problems is adherence to treatment, and especially because a lot of the medication for malaria, the antimalarials, are purchased in the retail sector. The question was, how do these individuals make these decisions? There's uncertainty about what your illness is. There's uncertainty about what the treatment is, what the effectiveness of the treatment is, and how well you're going to be after all of this. So if you sort of run a quick thought experiment in the back of your head about how one would really ask or really study what's the role of expectations, it's not actually very easy to do, because what you would need to do is to first measure the priors that people start with, then give them information, then study how that information helps them update their priors, and then look at observed behavior. A problem is most of the research we are able to do does not do all of this. We might measure some priors, and then we measure some posteriors, and we observe some behavior along the way. When we started the project, we wanted to do it right. It turns out doing it right is very, very hard, and we fell very short. So as you will see, what we are able to do is only a quarter of the way. So I don't want to oversell the results or what we did. So what we are going to do here is first we are going to look at, I'm going to show you something about the association between malaria status, beliefs on malaria status, and behavior in the context of testing for malaria and the treatment, right? Because for better or for worse, I cannot exogenously vary somebody's beliefs all that easily. Which goes back to this idea that if we really wanted to do this right, we'd take somebody with fever, half of them we'd give them information, the other half we would not. Of that information, half would be randomly, we would tell some people you have fever, and randomly we would tell some of them you don't have fever. Much of this is unethical, so we are not going to go there. Okay? So what we were looking at is this context where Kenya was in the process of introducing a massive national subsidy for its ACT programs. And my colleagues, Wendy and Liz and others, we were all doing this large study on trying to understand what would be an alternative way of a test and treat regimen. That is, you give subsidies for RDTs, and once you have a subsidized rapid diagnostic test, then the results from the test hopefully should help people make better decisions. The context again here in Kenya is there's an enormous amount of overprescription and overconsumption of anti-malarial drugs for simple fevers. And right now ACT is the only last one drug left, and if we all have resistance to ACTs, then we are doomed. So that was the context we are working here. So the experimental design that we were working with was a cross-randomized RDT and ACT program where individuals receive subsidies for RDT, some receive subsidies, some didn't, and only conditional on a positive test for malaria, they received a subsidy for ACT. That's not going to be the focus of our study here. What we also did is we collected information on beliefs about malaria and beliefs about a bunch of other stuff, including effectiveness of treatment and how much they believe test results. So what I'm going to do today is then look at the association between prior beliefs that what my fever today is really malaria or not, and how that predicts my behavior. I'm going to look at whether you get tested and whether you purchase ACT, which are the two main things that we are looking at. So we control for a whole bunch of things that are useful in this context: sociodemographics, levels of subsidies, prior beliefs, and so on and so forth. A whole bunch of enumerator and community fixed effects. As you can imagine, this is a difficult question to administer, and you might be a much better person at being able to explain things than I am. So enumerator fixed effects becomes very important here. If we had time, I would show you the cool stuff in all of this, is this measurement of belief. So what we did as part of this project was we developed a touchscreen-based slider. And for those of you interested, please send me an email. We'll send you more information, and the paper will be out soon. The slider helps us elicit probabilities in single percentage points going from 0 to 100 or 0 to 1 using a touchscreen dynamic interface screen that you can use even with illiterate populations. It works quite nicely, actually. Okay. So the main result here is, did you get any malaria test or not? So of our 444 individuals in our study arm, we have, what you're looking at here is the priors on whether you have malaria, the fever you have, is it malaria or not? Your beliefs about a test, because at the end of the day, just because I got a test, there is, people understand there is a test positive, a false positive and a false negative. So do you believe this test? We also have levels of subsidies. And we also ask about whether they think an ACT is actually effective or not. What's surprising in this is the RDT subsidy is the only exogenous variable, right? Everything else could be fully endogenous in this case, so we can't make much out of it. But contrary to much of the other work you've seen so far, at least in this context, what we find here is it's really the price subsidies, the exogenous price subsidies, that's driving behavior in terms of testing. When we run these models without all the priors and stuff, nothing really changes. It's really just being driven by this exogenous variation. So the first thing we take away from here is that in this context of malaria testing behavior, my priors about whether I have malaria or not, or whether I believe a test or not, or whether this drug is effective or not, don't seem to matter very much in this particular decision-making setting at all. So with that, then we sort of try to take it to the next step and say, well, okay, can we say something about the purchasing behavior, whether I decide to purchase an antimalarial drug or not? This is where things get a little more hairy, because what happens is you give me a drug or a test, then I have to internalize the information from that test, and then I have to make the decision. Sadly, what we couldn't do was measure whether people update their decision immediately after the test or not. So we are not able to really answer that. What we did instead was go back 2 weeks later and ask them ex post what happened to your prior, in this case, then we measure their posteriors 2 weeks later. So priors, when you look at the priors and ACT purchasing, what you notice is that the malaria negative folks, there's no relationship between their priors and whether they purchase malaria or not. Among the ones who did not get tested, not surprisingly, it's fully self-selected, right? I got a voucher and still decided not to get tested. There's a huge relationship between my priors and whether I buy drugs or not. We do see updating, except I will not tell you that this updating is because of information, because as I mentioned to you, these are posteriors that were collected substantially later. So it could be because of a whole bunch of reasons like ex post rationalization, which I think is the biggest explanation here is you're asking me 2 weeks later why I did what I did, and I could just update my prior posteriors. And consistent with that, we see evidence that among the malaria negative folks, the purchased ACT is very highly correlated with the posterior probabilities. But again, none of this is causal. My interpretation is all ex post rationalization. And so that's where it is. If anyone's planning to do more work on this, please let me know. I'd be happy to share our sliders. So let me stop.
Questions for this last paper?
Hi, I'm Alex Gertner from University of North Carolina, Chapel Hill. Thank you for the presentation. It's really wonderful, and I think this kind of work where incorporating people's beliefs and level of information into models is incredibly important. So I have two questions. One, did you do any validation work on the slider, anything like cognitive interviews or factor analysis? And two, did you consider doing any qualitative interviews with the patients to find out what was their reasoning or rationale or how they responded to the test?
Thank you. And great to see you from North Carolina.
Yeah.
Go Tar Heels, I guess I can say now. There's not too many people from Duke here except Indrani, so it's okay. So the second question, I don't think we did qualitative interviews, but I can check with my co-authors. They've been collecting a ton of data in Kenya, so maybe we can find that out and get back to you. On the validation, we did try to do validation in this particular sample and setting. It bombed pretty spectacularly because of a bug in the original slider, because of which enumerator fixed effects were perfectly correlated with the study arms, and so we couldn't really ask if the better recall was because of the enumerator or not. So then we redid the validation in a different setting in India, a slightly modified version of that tool. And the good news is the estimates are just as precise if you were to use beans or not. It's slightly faster, but respondents are much happier. So when we ask them, if you had to answer a battery of 50 questions with this tool versus with beans, how likely would you stick with the interview and things look better? But I don't think it's much more precise. It's not like the beans are giving us false answers.
Did you look at anything related to people's ability to conceive of what a probability is?
Yeah,
or,
we did everything from their ability to predict probabilities. We asked questions about nested probabilities, whether they are able to report things that are fairly complex, and they do surprisingly well.
Great,
Thank you.
Thank you so much.
Okay.
Our presenters did such a good job. We actually have 9 minutes, so let's open it up to questions and comments to any of the presenters. And if a presenter gets a question, if you could sort of come up to a mic just so the online audience can hear the questions as well. So floor is open. In the back, yes.
Sorry, if you could stay on this page. My question is related to the previous question, and that is, can you be sure that it's that their priors don't matter, or could it be that you're not, that you need a better measurement of beliefs? In other words, can some of it be attributed to the fact that maybe you're slow? It has to do with validating the slider.
Right. Well, so a relevant answer would be, if we had done this differently with beans, we wouldn't have any different answers, because we measured their beliefs with beans multiple different settings. Oh, that's the standard method through which beliefs and expectations are elicited in rural settings, where you give individuals a set of 20 beans and 5 different bins and say, tell me how likely it is that outcome is in A, B, C, or D, and then they put the bins there. Does that? No, sorry, I wasn't clear. We didn't get into the details.
Well, we're on the slider.
I knew this would be the cool stuff.
The slider has to start somewhere.
Right.
And I'm curious whether there's an anchor.
We tried at least 3 variants where one, it started at 150 and 0 during the validation. It didn't seem to matter all that much. I think the main thing was people really liked touching that thing and moving it around. But then, again, it could matter. It didn't seem to have any consistent patterns, but we need to get that validation stuff out soon. Yeah.
I can repeat if you need to. Go ahead.
So this question is for any of the presenters who want to take it, but since we're talking about behavioral economics and more classic methods, like we often try to isolate the individual. Parts are a perfect example. We want to separate the person so that we can really measure the individual beliefs or how that affects the outcome. And of course, there's a reason to do that. It's very important to distinguish it. But in many cases, people are highly influenced by the social context that they're in. So what role do you think that has in studies? Is it something that's always going to be sort of not a role of behavioral economics to look at, or are there ways that we should be looking at that and considering it?
So the general question was, how do we incorporate the idea of social context and potentially social influence when we're thinking about behavioral economic models of individual behavior? And it's open to any of the presenters that want to come take it.
Can I add to that question? Because I actually wanted to ask Lawrence a very similar question, is when you're thinking about doctors, if I'm part of a team, it's not just my performance, right? Because the patient's outcome is a function of everyone. So it's very possible that my colleague's experience could also matter for how I update my beliefs at this point. So when you're thinking about how doctors are responding to their cold hand fallacies in this case, would they be responding to their colleagues' experiences as well, or?
Yeah, sure. I guess I'll. Thank you. Yeah, thanks for the question. I think that's a great question. I guess I'll address your question first, and then maybe I'll add a comment about that if I remember. I think you're absolutely right. I think whether I can figure, so the data that I've applied for would have data on the hospitals and the physicians, but not necessarily the close team that the physician works with. So I don't know if I can do anything empirically interesting with it. I'll give it my best shot, but I do think there's actually a couple of interesting things that are going on, because physicians a lot of the times work as a team and think as a team. One could be that, for example, physicians learn from each other's recent past. It's totally plausible to me. It's also possible that they don't want to look bad compared to the team's mean performance. So that might have a different effect. It would be incredibly interesting for me to be able to look at that. I'll give it my best shot. But yeah, thanks for the comment. As to your question, I think I totally agree with you. I think the social influence is a huge part of how we behave and how we make decisions. Of course, hot end fallacy is not a great context to talk about social influence. That said, I do think there are a lot of behavioral economists working with peer effects and social influence, social networks. There's a huge literature that's growing that exactly studies that. So I do agree with you that I think it's a very important area, and it certainly affects our decision making, certainly mine. Thank you.
Yeah.
So I follow exactly the same idea about the social networks, and I agree completely with you. I think this is what we are in this study realizing, that actually consultant surgeons who are an extremely how can I say, egocentric career base, they tend to follow each other and they influence each other's decision, even the level of information they have about certain medical procedure. So that's the direction we are taking right now with a further study that tries to model in different ways how actually these social networks between consultant surgeons are happening, because that's another issue, right? Lawrence said very well. I mean, we can, with our data, we can, our rich data, we can very easily track people's inside an hospital and inside a specific specialty. So we see in each year, you know, each moment actually of time, who is in there and who is doing what. So there is some level of observables that we can exploit there. But of course, is that the case that people that are in your ward or that are in your department are actually the ones that are influencing you? So we are not completely sure about that. That's why we are taking several approaches, and we are also looking at social networks from the perspective of training. For instance, we believe that, as it is for economists, we tend to be influenced by whom we are, who we meet when we are studying economics. So that's another direction we are taking right now. We are modeling training networks to see if that's the case as well. Also, I mentioned briefly in my presentation, we can identify who are the pioneers of doing something in this wide network, which is the English NHS, and we can definitely see how far away in terms of links, using like a LinkedIn kind of approach. We can observe the distance that each of the consultants has in relation to those pioneers. So if we have an extremely successful professor of surgery and doing a specific technology which is recognized, you know, as being cost effective, but there is some risk in me as an anonymous consultant in hospital in a rural area to take that, maybe if at some point I meet that person, that might change my mind or not. So these are the different approaches we are taking, and I completely believe that we are influenced by others. Now the question is, how are we influenced? If it's negatively or positively. Thank you.
All right, I see it's 9:30, so if you could all help me thank the presenters for a great session. And I will say, as a member of the scientific committee, we would love feedback on the short presentation form of a session. Let us know how you think it went as an audience member or as a presenter. We'd love your feedback. But thank you. Enjoy the rest of the conference.